During the 2016 American Academy of Ophthalmology meeting, Duke Eye Center held educational presentations in our exhibit booth. We hope you enjoy watching the faculty sharing the latest in ophthalmology.
So today I want to talk a little bit about an evidence-based approach to amblyopia management and specifically talk about some of the pediatric eye disease investigator trials that I use in my practice every day to sort of help guide me in amblyopia therapy. This is also going to be a little bit of a Mythbusters, so there's some myths about amblyopia that I want to debunk today for you. So I have no financial disclosures, but I would like to acknowledge my partner, David Wallace. Luckily, I'm acknowledging him because he's actually here today. He brought the donuts, which was really great, and he also shared slides with me. David is the PEDIG network chair, so he knows even more about PEDIG trials than I do. So some of the myths I wanted to talk about today are that glasses alone are not an effective amblyopia treatment, particularly in strabismic amblyopia. Sometimes we think if the kid doesn't get straight in the glasses, then glasses aren't going to treat the amblyopia. And we're going to talk about that a little bit and see that that's actually one of the myths. There's also sort of this idea among some folks that near activities or other specific activities are an important part of the patching efficacy. And we're going to talk a little bit about why that's a myth. We're going to talk about patching in older children. I know a lot of people will stop after age 7 or 8 and feel like it's too late. There's nothing else that can be done. And we're going to talk about what to do when vision stops improving, whether we should keep going, ramp up patching, stop, give up, or what we should do. So just quick review, amblyopia, the definition is decreased vision in one or both eyes, and it occurs when the visual system is immature. So we usually think of it occurring up until kids are about 7 to 10, but you'll see from some of the studies we talk about that that may not be completely true, that maybe the period of plasticity is much longer than that. And it results from abnormal visual inputs to one or both eyes. And I like to emphasize with parents that amblyopia is really a brain problem. It's not a problem with the eye. This is brain damage from loss of neurons. This is a classic example where they took monkeys, and this is a lateral geniculate nucleus of a monkey that's normal, and you can see all these nuclear layers, and then they sutured one eye closed, and you can see in this lateral geniculate nucleus there's fewer neurons. So it's actually a change that's occurring in the brain, a structural change. So amblyopia, just to review, you guys know all this, but the most difficult to treat type of amblyopia is deprivation amblyopia from something like a cataract or a ptosis. You can have strabismic amblyopia, which is the second most difficult to treat. And then you can have refractive amblyopia, which can be unilateral from anisometropia or can be bilateral from high hyperopia in both eyes or astigmatism or some combination of those things. So in terms of treatment of amblyopia, the first thing is to remove the obstruction in the visual axis. If they have a cataract, you got to get the cataract out. If the lid is blocking, you got to get the ptosis repaired. Glasses if necessary, patching of the sound eye, and then some form of penalization of the sound eye is another option, either pharmacologic or optical. Patching's been the gold standard of amblyopia treatment. This is an old cartoon from the 70s, Charlie Brown, and it says, with nothing more than a simple eye patch, we have brought amblyopia to its knees. So this has been around for forever. We've been doing patching. And you say, why would we use anything else? We know patching works. Well, any of you that have tried to patch kids, if anybody's patched their own children, it's very difficult and compliance can be an issue. When I trained many years ago, 20 years ago, we did full-time patching on everybody. And that was really effective, but really hard to do. And I'll talk a little bit about how things have changed. I do much more part-time patching now. There's a social stigma associated with patching, especially if kids have to wear their patch to school, and some kids will get skin irritation from the patch. There's many different ways to do penalization therapy as an alternative to patching. The sort of most commonly used one is atropine, and the atropine can be used either daily or twice a week, depending on the kid and how things are going. There's optical penalization, including plano lenses or excessive high plus power lenses. You can use atropine in combination with a plano lens. You can use a Bang-Girder filter, which is what this is. Or you could use very fancy translucent tape if you don't have a Bang-Girder filter. Bang-Girder filters are cheap though, they only cost $7. So that can be a good option as long as the kid is not gonna peek over the glasses. So what is PEDIG? So some of you who aren't pediatric ophthalmologists may not have heard of it or know exactly what it is, it's the Pediatric Eye Disease Investigator Group. It's a network of about 250 both community and university-based providers at about 100 sites. And one of the things that's unique about the Pediatric Eye Disease Investigator Group is that it includes both pediatric ophthalmologists and pediatric optometrists who sort of band together in both university and private practices, so we get a good spectrum of real-world pediatric ophthalmology to do multi-center studies in strabismus, amblyopia, and other eye disorders that affect children. And one of the really unique things about PEDIC is that for the first time, we actually have randomized controlled trials in amblyopia. We didn't have that before. We just did kind of what our preceptors taught us to do, and we didn't have nearly as much evidence-based studies to go by. PEDIC is funded by the National Eye Institute, and there's a central data coordinating center called the JABE Center that's in Tampa. So PEDIC has addressed some of the myths that we talked about earlier today. The myths that we're going to talk about today is, does patching work in older children? Do near activities enhance the effect of patching? How well do glasses alone treat amblyopia, particularly in strabismic children? And what if the visual acuity stops improving when you're doing part-time patching? What should you do at that point? So let's address the first one. Does patching work in older children? So ATS3, and all the PEDIC studies have a number to them. Amblyopia Treatment Study 3 was an evaluation of the treatment of amblyopia in children aged 7 to 18. So these are old kids, kids that you might have thought before, well, what's the point? They're too old for treatment. There was 507 patients aged 7 to 18 with visual acuity in the moderate to severe range of 20/40 to 2400. Most teenagers with a patch are not smiling like this lovely girl is. That was posed for the picture. It was a randomized controlled multi-center clinical trial, and the treatment groups consisted of a control group that did optical correction only, so they were put in their best glasses, and an active group that did their glasses plus everything you could think of. They did patching, they did atropine in the younger kids, and they also did near activities because it was just kind of the kitchen sink approach. Give them everything we can to see if these older kids are going to respond with amblyopia treatment. And the primary analysis was a comparison of the proportion of the treatment responders between the treatment groups. And responders were kids who improved at least 2 lines of vision, 10 letters or more, at least 2 lines. So it was a clinically significant response to treatment. So if you look at the primary results, the responder rate between the two groups, the 7 to 12-year-olds, the younger kids, did really well. The yellow is the augmented, so they had their glasses plus the kitchen sink approach, everything we could think of. And then the blue is just glasses alone. And you can see that the augmented treatment in the 7 to 12-year-olds did much better than glasses alone. Interesting, glasses alone improved things quite a bit too. In the 13 to 17-year-olds, it's not a very impressive result, 25% in the kitchen sink approach versus 23% in the glasses. However, if you take those 13 to 17-year-olds and you break them down into kids that had already had lots of treatment when they were little, maybe when they were 3, they patched full-time for forever, and kids that had never had any prior treatment in these teenagers, you found something very different. And that was that with no prior treatment, even these really old kids, the teenagers, had really good improvement with the addition of patching, atropine, and near activities. Actually, the older kids did not have atropine. They just had patching and the near activities in addition to their glasses. So, you know, does patching work in older children? Yeah, especially if they've not had any prior treatment. So this is a big change for me. I had always patched kids that were a little older, up to the 12-year-olds. But now, if a teenager comes into my practice that's never had treatment, or maybe, you know, you have to ask them carefully when they come in. When they say, yeah, I've had treatment as a kid, how much did you really patch? Was it like 1 week of trying and it was really only 15 minutes at a time, and then the 3-year-old was ripping the patch off? And in those kids, you might consider offering a round of patching in addition to their glasses. They may or may not take you up on it, but it's worth a try because they have a really good chance of responding. Other options for older children. So levodopa has been something that people have looked at for a long time for older kids and adults for amblyopia therapy. So PEDIC did the Amblyopia Treatment 17 was a study of levodopa for residual amblyopia in older kids. Well, so one of the ways I interpret it is some kids just may not improve. So, and you know, with patching, I always think when you start patching, you see the best results. And I always think about it like somebody that, you know, has that weight to lose. That they've got 50 pounds to lose. The first 25 is easier to lose than the second 25. And sometimes the last 5 pounds are impossible. And patching seems similar to me, that sometimes you get the best effect when you just start it and you're just getting going. So if they've never really had treatment, there may be, you're kind of getting the low-hanging fruit there of kids that may have some improvement, versus if they've already had treatment, they may have already gotten some improvement. They didn't get all the way to 20/20, but they got the improvement they were going to get. Because remember, those responders improved 2 lines. Some of them were starting pretty severe. So, but 2 lines, that's a significant improvement. So they were, it was, David, I can't remember. I'm sorry. I'm supposed to be repeating the questions. I forgot to do it. The question was, how long were the 13 to 17-year-olds patching a day? I don't remember the specifics. Yeah. 6 hours prescribed patching. How much they were really patching, I don't know. That was also before we knew about, you know, should we do near activity, so they were just given everything. So the Levodopa study looked at kids, again, a little bit older, 7 to 12 years of age, who had strabismic and or anisomtropic amblyopia. They were already patching at least 2 hours a day for at least 12 weeks and had stopped improving. So they were sort of stabilized. They'd gotten the effect they were going to get from that initial 2 hours a day of patching. And they were randomized to continue. All of them continued their 2 hours daily patching, but they were randomized to either Levodopa or oral placebo. It's a double mask study, so the investigator didn't know what they were on, the parents didn't know, the kid didn't know. And they did 16 weeks of therapy with a primary outcome at 18 weeks after they had been weaned off their Levodopa. And it showed that there was a little bit of improvement. So the mean change in vision from baseline, the number of letters, was a little bit higher in the Levodopa group than in the patching alone group. And it was a change in about 1.4 letters, but the confidence interval spanned 0. The proportion that improved 10 letters or more was also a little bit higher in the Levodopa group, but it wasn't a huge difference. And the conclusion from this study was that for children 7 to 12 years of age with residual amblyopia, so they'd already been patching and gotten as much as you could get out of them, 2 hours of daily patching with the addition of Levodopa was not associated with a meaningful improvement in vision. Teeny improvement, but probably not a meaningful improvement in vision. Keep in mind, it wasn't studied as an initial therapy. These were kids that had already sort of maxed out on 2 hours a day patching. So we don't know what would happen if you gave Levodopa at the beginning of patching treatment. So Levodopa gets converted to dopamine in the brain, and there's been lots of studies that show when you give people dopamine that it enhances vision. So if you take normal people that are 20/20 and you give them dopamine, you can actually get much better visions while they're on the Levodopa, which is sort of interesting. I think it's been looked at even in sort of military applications and things like that. Could you get sort of superhuman vision? That effect goes away when you come off the Levodopa. So the idea was, what if we put these kids on Levodopa and we gave them sort of superpower vision while they're patching? Is that going to enhance things? And it wasn't a huge difference. So I don't currently offer Levodopa as part of my treatment plan. So let's talk about another question. Do near activities enhance the effect of patching? Does anybody here prescribe specific activities to do with patching? Yeah. Yeah. Yes, so when they're busy in school. So this is interesting. I told you that PDIG does, it's a collaboration of both pediatric ophthalmologists and pediatric optometrists. In the optometry community, it was really common for them to prescribe specific activities to be done with patching, and there was a strong feeling that near activities were a really important component of patching. So PDIG designed a study to answer that question. It was ATS-6, a randomized trial of near versus distance activities while patching. These are in the younger kids, the 3 to 7-year-olds. So all of the kids, 425 children. The advantage of PDIG, by putting all of our patients together, we can do these big studies. So all of these studies have a lot of patients in them, and they can be randomized controlled trials, which I couldn't do in my own practice, certainly. These kids had moderate to severe amblyopia ranging from 20/40 to 2400, and they were randomized to 2 hours of daily patching with near activities or with distance activities. And there was a lot of discussion in the planning committee of what constituted a near activity and what constituted a distance activity, right? So if you're eating dinner but watching TV, what is that? But there were specific prescribed activities for them to do. Playing outside, watching television, those were distance activities. Being on their iPad or reading a book, their schoolwork, near activities. And it was very elaborate. They had a diary and check-ins from the coordinating center to make sure that they were doing the activities they were supposed to be doing while the patch was on. And there was masked exams at 8 to 17 weeks. And if you look at the difference, they're pretty much identical between the distance and near group. There really wasn't much difference there. They were almost identical. So the good news is, I usually tell folks, you know, you don't really have to worry about what the kid is doing. When the subset of those with severe amblyopia was further analyzed, there was maybe the suggestion of a little tiny bit of advantage with near activities. But in general, I think with severe amblyopia, it's so hard to get the kids to patch anyway. I usually tell families, don't worry what you're doing. They just have to have the patch on. I do clarify while awake. I've had families patch 8 hours a day, and it took us a while to figure out why we weren't making any progress with 8 hours a day, and I finally realized that the mom was putting the patch on every night faithfully when the child went to bed, and really it was no problem. She could continue doing that as long as I wanted her to. So clarify that awake is good. So what about how well do glasses alone treat amblyopia? So Amblyopia Treatment Study 13 looked at optical treatment of strabismic and combined strabismic anisymmetropic amblyopia with spectacles. These were 3 to 7-year-olds that had had strabismus or previous strabismus surgery. And the amblyopic vision, was the moderate to severe, 20/40 to 2400. They had had no prior spectacle wear or amblyopia treatment. And one of the key things about this, because you say, well, of course, if you have an accommodative isotrope and you put them in your glasses, it's going to treat the amblyopia by getting them binocular, and they're going to do better. These children were still strabismic in their spectacles. So even after they had the appropriate correction, they remained strabismic. And if you look at the improvement in visual acuity between baseline and 18 weeks, you'll see that the children that had combined anisymmetropic and strabismic amblyopia had 2.3 lines of improvement, and the kids that had strabismus had 3.2 lines in spectacles alone. Who would have thought that? I mean, that was a surprising result. The percent that improved over 2 lines was 69%. So how can an amblyopia improve with spectacles alone when the kid is still strabismic in the spectacles? You'd think there's still a strong fixation preference. They're still getting suppression from that fixing eye of the strabismic and amblyopic eye. Maybe the amblyopic eye is fixating at certain times, so maybe it's sometimes either at distance or near, the kid is switching fixation and you don't see it in the office and they're getting some stimulation. We really don't have a good explanation. This is our attempt. You know, this is what the data showed us, and it wasn't what was expected. So how well do glasses alone treat amblyopia? Really well, even for those kids that remain strabismic in their spectacles. And some may never even need patching. Some kids resolved all of their amblyopia with glasses alone. So this for me has been a big change in my practice. It used to be I'd have a little kid come in and I'm pushing the parents, you got to start the glasses, you got to start the patching, you got to do all this stuff at once. And it's really hard. Now I say, you know what, let's fight one battle at a time. Let's get your kid wearing glasses reliably, and then hopefully the vision will come up. It will make patching easier, and we're only fighting one battle at a time. So this has really changed for me how I do things, that I start glasses alone, see what we get with those, and then add the patching. What if visual acuity stops improving with patching? So this is important because, you know, in the olden days we used to do full-time patching. I've changed to part-time patching. A lot of other folks have too. But the question, a lot of these kids don't seem to get all the way to 20/20. I've noticed with the part-time patching, it seems to take longer because, you know, full-time patching is very effective and works very fast, but it's hard to do. Part-time patching is much easier accepted, but it takes longer, and not everybody gets to where they're going. So what to do? So ATS 15 looked at a randomized trial of increasing patching for amblyopia. 169 kids, younger age group, 3 to 8, with stable residual amblyopia. So they had been patching 2 hours a day and weren't getting any other improvement with that. They'd been stabilized at their vision and weren't quite to their amblyopia had not been fully treated. So they were randomized to either continue going 2 hours a day or at that time to increase to 6 hours a day. And the primary outcome was at 10 weeks. And if you look at 10 weeks, the visual acuity, the difference in the mean between the groups was not very much. But the proportion that improved 2 logmar lines or more was much higher in the kids that had increased to the 6 hours a day. So 18% improved, we continued 2 hours a day, which is sort of interesting too, because we had said they had stopped improving with 2 hour a day patching, but yet when we carried the study out even longer, 18% of those kids that just continued 2 hour days patching still improved, and a lot more of them improved as they ramped up to 6 hours a day. So if you look at the 10-week outcome, this is the ones that continued 2 hours a day. The peach colored is the ones that ramped up to 6 hours a day. And at the 10-week outcome, many, many more had improved in the 6 hour a day patching. The study was continued out until the kids stopped improving. So 10 weeks was the primary outcome, but it kept going. And if you continued following the kids in their either 2 hour a day or 6 hour a day patching, you see that actually the 2 hour a day ones kind of continued to improve too. And almost 40% of them, if you look at their best visual acuity post-randomization, had caught up. But there was still a higher proportion in the 6 hour a day. 50% of those kids got more vision. So if visual acuity stops improving, if you're doing 2 hours a day patching, consider ramping up. And if they can't ramp up, you might consider asking them to hold on a little longer before you completely give up. Because some children, even when you think they've stopped, will have a little bit more juice to get a little bit more improvement. So I hope that I have been able to debunk some of these common amblyopia myths and tell you some amblyopia truths today based on the evidence and randomized controlled trials that glasses alone are an effective amblyopia treatment, even if kids remain strabismic in their glasses. Near activities are not important for patching efficacy. Patching is effective even in older kids. If I can drive one point home, it's try patching in your older kids that have not had previous treatment. Offer it as a possible solution. And once vision starts improving, there is a role for increasing treatment. And some of my patients, I even offer full-time treatment. We don't have that study to know what happens if you have pooped out at 6 hours a day. Would full-time give you anything more? I don't know the answer to that. I usually offer it and say, look, here's a good way to figure out, you know, and be sort of done with patching, is to do a short trial of full-time. And I thank you all very much for your attention, and I hope we still have donuts over there. Please get a donut. You stayed for the whole thing. You've earned it, and I really appreciate you coming today. I'm happy to take any questions. Yeah, thank you. How do you stop patching? Great question. So that we know that when we stop patching, there was another study, I can't remember the number of it, but that looked at what happens when you stop patching. And when you have a kid that you've effectively treated and you say, great, I'm where I want to be, we know that when you stop patching, about 25% of those kids in the first year will have some backsliding. So when I stop patching, I always tell the parents, we're taking a break from patching. We may not be stopping completely because we may have to start up again. We're taking a break. And then I follow them closely in that first year. Most of the kids that slip will do it early. Some will do it very late. The other thing we discovered that if you're patching, if you've ramped up to that 6 hours a day, or maybe you started at a higher amount, 6 hours a day or full time, kids were more likely to slip if you stop the patching cold turkey than they were if you taper. So I tend to taper patching. So if we're going 6, I'll tell them, okay, why don't you take it down to half of whatever you're doing, come back again, and you know, in 10 weeks, and we'll see where you are. And if you're stable, we'll cut it all together and continue to watch you in another 3 or 4 months. I follow them pretty closely, and a lot of kids have to start up again. Any other questions? Yeah. Right. So 2040 was the lowest range, and I think the moderate went up to 2070. Is that right, David? Moderates to 20. Yeah. Yeah. So 2040 was the lowest. A lot of the kids were worse than that. It's amazing how many kids, though, you just can't get past that, 2040 level. So, yeah. And I always think in North Carolina, 2040 is the cutoff for an unrestricted driver's license. So to me, getting better than 2040 at least, is a really big deal. And 2070 is the cutoff for a restricted driver's license. So I always use that as a carrot for the family. If we could just get a little more, if something happens to the other eye, you can still drive. So, any other questions? Thank you all so much for your attention.